Welcome to the SAB's May educational webinar, Transbronchial Lung Cryobiopsy to Infinity and Beyond. Before we get started, a few housekeeping items for everyone. You all have joined in a listen-only mode. You may ask questions throughout the presentation using the question feature that is located on your control panel. We will address all the questions at the end. Dr. Gupta, who is on the SAB Education and Program Committee, will be introducing tonight's speaker. Dr. Gupta?
Hi, everyone. We're so glad that you could join us for this topic, transbronchial lung cryobiopsy. We have Dr. Alejandro Aragaki, who will be speaking to us today. He is an assistant professor of medicine at University of Cincinnati, as well as the director of interventional pulmonology there. Dr. Aragaki, take it away.
Thank you, Dr. Gupta, for the invitation. Let me just move this because I see two things. Okay. Well, thank you for the invitation. It's a topic that I deeply enjoy since we do quite a few of these transbronchial lung cryobiopsies in our institution, and I hope in the next 45 to 50 minutes, I can get a message conveyed to you and see what you think at the very end. Let's see. I have no conflicts of interest to disclose about this particular presentation. And what we'll do is the agenda that I have, we'll have a brief discussion of cryobiopsies prior to 2019. I have a little disclaimer because some of you might actually know that recently the IPF clinical practice guidelines were published. So when Dr. Gupta asked me to just talk about this, I made in my mind an agenda, and then I had to modify it a little bit. But we'll do some review of cryobiopsy publications from before 2019 up to 2022. We'll focus initially what we thought it was the right thing to do when we're talking about a new technique to biopsy the lungs, particularly for ILD, which is diagnostic yield. And then obviously complications, including morbidity and mortality. After that, we'll talk a little bit of how we switched our view of biopsying the lung in IPF when compared to surgical lung biopsy. I'll have a word or two about the cryobiopsy experience around the world, some indications beyond parenchymal lung disease, and then we'll just have a minute or two with the new updated IPF clinical practice guidelines. So before all of that, and disclaimer, there are two expert statements about how to perform cryobiopsies, indications and contraindications, how to make the procedure safe. And one came in 2018 on the Respiration Journal from Europe. And then in Chest 2020, a US journal, pulmonary journal, also released their own guidelines. So as I was saying before, why did I say 2009? Because in 2009, Professor Hetzel and his group back in Germany published the first case series about the application of cryotherapy for lung biopsy in interstitial lung disease. In 2014, there were already 11 publications, and then in 2010, there were 34. But if you do the search in PubMed, you can actually see that there is a growing number of publications, and obviously 2022 is a little bit lagging behind because we're not done with a year, but my guess is that it's going to still increase. So up to April of 2022, when I did the research, I found 343 publications. So why we end up having cryobiopsy for suspected IPF? And this is coming from the IPF official statement from 2018. So if you ignore the row in the center, you can see that transbronchial lung biopsy itself, an histologic diagnosis for IPF is less than a flip of a coin, is 36%. So you're gonna have almost 2/3 of undiagnosed cases. Whenever you compare it to surgical lung biopsy, almost 90% histologic diagnosis, and undiagnosed cases are 11%. So around 2018, it was estimated based on the available data that we have for cryobiopsies that the histologic diagnosis was 79% or 80%, and undiagnosed cases was 20%. So just following logic, right, a logical approach, the pieces or the biopsies get bigger, so you actually have a better diagnostic yield. The complications for transbronchial lung biopsy in this clinical guideline, the pneumothorax was up to 10.2, which I think is extremely high for transbronchial lung biopsy, but nevertheless, that was published. And then persistent air leak was up to 6.1% of cases, probably because, or it's a reflection of how diseased the lungs were, or how difficult it was to do the biopsy itself. For transbronchial lung cryobiopsy, we've always talked about or discussed about pneumothorax, persistent air leak, and bleeding. And obviously for surgical lung biopsy, we're talking about the risk of having an IPF exacerbation and peri-procedural mortality. So for those of you who haven't seen or read about cryobiopsy, this is a cryoprobe, and it looks like a 1.9 millimeter reusable cryoprobe. This is the console in here that is attached to a nitrogen tank. And this is a zoom in of the cryoprobe itself. And in here in formalin, you can see the biopsy. So practical purposes, when you compare the size of a transbronchial lung biopsy, that's going to be like 1 or 2 millimeters. It's going to have a crush artifact just because of the nature of the tool that you're using. The cryobiopsy looks more like a Q-tip, and that's how I tell my trainees. But the largest diameter is usually around 5 millimeters or more. So in terms of area, it's usually 3 to 5 times bigger. And the bigger area that you get with a cryobiopsy allows for better characterization of the pattern of injury, and then you can actually get a better diagnosis. But this is the old console from Araby, who is proprietary of the cryoprobe machine and technology. And then kind of they wise up. They got a cryoprobe Araby 2.0, which brings you a 1.1 cryoprobe, a 1.7 as opposed to the 1.9 reusable, and a 2.4 as well. And you can see in here that they did studies, and you can see that there's the expected proportion of alveolar tissue and bronchial tissue. That's what they claim. I think both the 2.4 and 1.7 for the 2.0 system, or the 1.9 and 2.4 for the reusable system, with adequate technique, there's not going to be much of a difference in terms of how much bronchial wall or how much alveolar tissue you get. So as I was mentioning, in 2009, Dr. Hetzel and his group, I should have mentioned Dr. Babiak first, but it's mainly Dr. Hetzel and his group, described the first case series of transbronchial cryobiopsy. I'm going to go back before I forgot to mention this, but when you connect all of these pieces together, there's a pedal, and when you press the pedal, there's a sudden release of the nitrogen gas that goes to the tip of the cryoprobe, and the rapid expansion of the gas creates an ice ball, and the temperature goes rapidly down to minus 89 degrees Celsius. So you're getting a little ice ball on the tip of the cryoprobe. When you are distal in the lung, not touching pleura, hopefully, then you freeze that area, and then you can retrieve the biopsy. So Professor Babiak and Hetzel just did this retrospective feasibility study. And it's interesting because it was published in 2009, but the retrospective case series the initial one was in 2006 from July to December. So what they did is they included 41 patients with diffuse lung disease, at least 18 years old of age, at least with a PaO2 of 60 millimeters, while on nasal cannula 2 liters per minute, or on ambient air, and no coagulopathy and no evidence for pulmonary hypertension. So what they did is they just did at least 1 cryobiopsy and 1 transbronchial biopsy under fluoroscopic guidance. They selected the airway where the biopsy instrument would be best visualized. I have a picture in the next few slides what I mean to that, and it's the airway that is perpendicular to the chest wall. So that's the one that you actually have the perfect 90-degree view. And they targeted a distance of 10 millimeters from the thoracic wall. As I was mentioning before, the area for transbronchial lung biopsy, the usual biopsies, is 5.8 square millimeters, and the transbronchial lung cryobiopsy specimen area was 15, which was statistically significant. When they did the cryobiopsy, they encountered 2 pneumothoraces, mild bleeding, which is a little bit of a problem because nobody knows what is the exact way to quantify bleeding during a biopsy. Hence, there's a lot of variation in terms of reporting how much bleeding you actually have after a biopsy, whether it's mild, it's moderate, it's severe. And understandably, there were patients also that underwent surgical lung biopsy, and those were the ones that didn't achieve any diagnosis. So basically 39 out of 41, or 95% of the patients reached a histologic diagnosis. So in conclusion, this is a case series in a retrospective case series in a single center. Transbronchial lung cryobiopsy could provide better quality, bigger samples for interstitial lung disease when compared to transbronchial lung biopsies. And in here, which is really interesting, you can actually see here, right? It's like what you do in multidisciplinary discussion. You get the history, you assess the lung function via PFTs and any other clinical markers, and then you find the correlation with CT. And you can see with only this, out of 41 patients, 11 met criteria for classic IPF or UIP pattern of injury. One was suspected to have hypersensitivity pneumonitis, and 2 had sarcoid. When you added tissue in this column, forceps biopsy, you had a lot more diagnosis, for example, NSIP or DIP or LAM, for example. But when you added the cryobiopsy, you see how in here the diagnostic yield for IPF and NSIP actually increases even more. So this is the one, or this is the study that is the inception for everything. After that, and I apologize, I was switching too fast. There were a lot of other centers experiences around 2012. There was a big case series from Vanderbilt. There was another one from Spain and another one from Italy, which are kind of like a landmark studies that followed Dr. Babiak and Dr. Hetzel's case series in here. With that, there was a growing interest on and focusing basically on the diagnostic of cryobiopsies for interstitial lung disease, comparing it to surgical lung biopsy and see whether we could rival surgical lung biopsy as a gold standard in terms of diagnosis. But then there were also discussions or descriptions of what happens if you don't have a pre-established protocol to just do transbronchial lung cryobiopsies. There's an interesting publication from University of Pennsylvania in which they describe their experience in which all of these experienced IP attendants were doing cryobiopsy so the best way they thought it would be, and they had some complications, and that sparked the discussion whether we need to standardize the technique or if anybody can actually do that. When you go to this, one of the first meta-analysis, and it was published in the White Journal in 2016, the histologic diagnostic yield had a pooled estimate of 83%, meaning if you could actually figure out anything going on in your biopsies themselves. The multidisciplinary discussion diagnostic yield was a little bit lower, but still 79%, which is probably the one quoted in the 2018 IPF guideline. The pneumothorax pooled estimate was 12%, and the moderate to severe bleeding was 39%, which again, difficult to ascertain because up to now, we haven't come with a uniform way of grading bleeding during a lung biopsy. But just because it was a systematic review and meta-analysis of basically mostly retrospective case series on a single institution or multi-institutional, the authors concluded that the diagnostic accuracy of cryobiopsy cannot be determined given the absence of direct comparison of the diagnosis of cryobiopsy with diagnosis derived from surgical lung biopsy within multidisciplinary discussion. That was 2016, right? So 2009, you have the first publication. 2012 is when a lot of institutional retrospective series begin to be published. And 4 years afterwards, we're just questioning whether, yes, it looks like it's good, it's reasonable, but we cannot say anything about accuracy because there's no direct comparison with the gold standard, which still is surgical lung biopsy. There's other meta-analysis that comes from QJM. I think it's a quality journal metrics or something like that, or medicine, I don't remember. It's from 2017. What I think is really interesting in here is that they actually pulled the diagnostic yield for transbronchial biopsy, transbronchial cryobiopsy, and VATS. or surgery, right? Interestingly enough, to me, I couldn't believe why the diagnostic yield was so high, 64, right, when we're talking that in the 2018 guidelines, the transbronchial biopsy diagnostic yield is like 35 to 38%, right? Then cryobiopsy was a little bit more generous, 84 instead of 79, and BATS biopsy around 88 to 91. Again, pneumothorax in single digits, moderate bleeding 21. Remember, the other one was 39. So basically, not a uniform comparison, right? But what I think it was really elegant of this meta-analysis is in a single center, they calculated how many patients per year would actually need a VATS biopsy. So they were saying, assuming an 84% diagnostic for transbronchial lung cryobiopsy, that would mean that only 6 patients would actually go to VATS after doing the cryobiopsy. So potential savings per patient during the first year would actually be 210 pounds, which is not much, but if you multiply it by 35, is over 7,000 pounds. And in the subsequent years, it would actually increase. And the difference between the first year and the second is they are calculating the cost of the equipment and the cryoprobes as well. So at least assuming everything was within reason in terms of complication rate, safety of the procedure, and diagnostic yield, probably transbronchial lung cryobiopsy will be cost effective for an institution that wants to start their program. So this is from the 2018 expert statement, where to biopsy, and what they come is with an elegant way of determining which is the area in the lung that you actually want to do the cryobiopsy. So in the central airways, the large vessels are protected by cartilage. So basically, you're not going to have any problems if you end up biopsying the airways. But we all know that IPF, ILD, NSIP, any of these conditions are happening in the alveolar area. So there's nothing to just, focus on here. If you go to the subpleural area, just because you're just beneath the pleura, you have a high risk of pneumothorax. And when you go to the middle part, which is just after the cartilage protected area of the airways, there's medium-sized vessels. So the experts postulated that if you do the biopsy too proximal to where you're supposed to be, or more proximal, you might actually have more bleeding. So the area or the target area is less or a little bit more proximal than the subpleural area, but far away from the medium-sized vessel zone. So for practical purposes, all experts agree that between 1 or 2 centimeters from the pleura or from you actually feel resistance. And that's what we actually do in here as well. And this is what you have in a fluoroscopic guided biopsy. You see the bronchoscopy here, and you can see the cryoprobing here. And this is kind of like the ideal view that you want to have, a perpendicular view, so you can actually tell or figure out how far or how close you are to the chest wall. There's an image from Google. It's not something particular that I pulled up from here. So after giving you the prior publications of what we were thinking, I'll go from 2019 and 2022 and mixing it a little bit with little data points in terms of complications, including morbidity and mortality. So as I was mentioning before, right, we were all chasing ourselves, like, is cryobiopsy as good as surgical lung biopsy, meaning we just care about the diagnostic yield itself. But after the 2016 meta-analysis, it was more like we've never compared cryos against surgical lung biopsy within a multidisciplinary discussion. So the shift was from diagnostic yield to how concordant is cryobiopsy in comparison to surgical lung biopsy. And in 2019 and 2020, there were 2 important publications which I consider landmarks in terms of concordance of cryobiopsy versus surgical lung biopsy. The first one, or the Cryobiopsy, was published in the Blue Journal, had 21 patients. And then the next one was published in Lancet Respiratory Medicine in 2020, the Cold Ice study. So interestingly enough, the Cryobiopsy study, the one published in the Blue Journal, stated that there was poor concordance between cryobiopsy and surgical lung biopsy diagnosis and within multidisciplinary conference. And the Cold Ice study kind of proved the opposite. There were important methodological differences. I'm not an ace in biostatistics, but from what I could gather after reading these 2 important articles back to back to back, like so many times, The Cryo-PID study was a multi-center study, included 21 patients, but they asked an expert pathologist to just render a single diagnosis from the samples without any access to data points from the medical chart. So while in cold eyes, there was 3 pathologists' interpretation of the samples. They interpreted the cryobiopsies in one session, and then obviously they identified all the cases, and they discussed the same patient, but with the surgical and lung biopsy samples as well. Just because there were no medical data points for cryo-PID, I think that was in detriment. Also, the expert pathologist was given only one shot or one chance to just give one diagnosis. Cold eyes appear to be or represent real life, right? So after this study, there was one that, at least when my mentor and good friend, Dr. Bensuken, started doing cryobiopsy at the University of Cincinnati, I believe our first case was at the very end of 2014. We got really excited about the new technology, about the prospects of having different centers publishing their experience. And at some point around 2017, we were actually thinking, okay, well, we're right now just moving from purely diagnostic yield to incorporate or have a comparison with a surgical biopsy, which is the gold standard. And we were trying to just do something like the CHILL study accomplished. We had a lot of issues, mostly financial. And the CHILL study actually proved what we were expecting today. It was going to be a hard study to complete, doing it only ourselves. The CHILL study is a comparison of transbronchial lung biopsies, cryobiopsies, and VATS biopsies for diagnosis of ILD in the same patient. Imagine that, right? And it was a prospective multi-center trial where they did sequential transbronchial lung biopsies, cryobiopsies, and surgical lung biopsies. It was so hard that, imagine, they had 16 patients enrolled in 4 years. It was 4 centers, so these centers enrolled 1 patient per year. Really hard, right? But what they did is, it's an elegant analysis of the agreement, the raw agreement between cryo and surgical lung biopsy for a multidisciplinary diagnosis. It was 68.75% with a Cohen's kappa of 0.6. I'll get into that. It's hard to understand. But I promise next slide will be better. And the raw agreement and Cohen's kappa for transbronchial lung biopsies versus cryobiopsies. And transbronchial lung biopsy versus surgical lung biopsy was much lower. So if you compare or you see the agreement between regular biopsy forceps and cryos, it was 50 with a Cohen's kappa of 21. And when you compare the transbronchial lung biopsy and surgical lung biopsy, it was even worse, 18.75 with a Cohen's kappa of 0.08. All of these biopsies were interpreted by the same expert who participated in the Cryo-PID trial as well. So as I was saying, right, when you're talking about, or you just reading about Cohen's kappa for agreement between 2 different modes of 2 biopsy modalities, the CHILL study showed a Cohen kappa of 0.6, which is moderate, where a Cohen kappa of 0.21 when it was transbronchial lung biopsy and cryobiopsy, which is fair. And then transbronchial lung biopsy and surgical lung biopsy, Cohen kappa was 0.08 or really poor. That's why nobody actually does transbronchial lung biopsies in interstitial lung disease workup. So there's another publication, and this is from Spain, and it's the multi-cryo study, a prospective multi-center study of patients with ILD, all needed biopsy, and they had 3 regular biopsies followed by 3 transbronchial lung biopsies. This is really interesting again, right? It's a poor diagnostic yield for transbronchial lung biopsies, 20%. And the multidisciplinary discussion diagnostic yield for transbronchial lung biopsy was 47.6%, which is much lower than what the CHILL study actually suggested. So when compared to the CHILL study, every biopsy was interpreted at each institution with unblinded pathologists. So that bears a question, right? So what could explain the marked difference in multidisciplinary diagnostic yield or multidisciplinary discussion diagnostic yield for cryo with a chill study, 62.5% versus a multi-cryo study. And this is not something that they did wrong or anything. It's just a description of what they did in their institutions, right? But in 2019, Dr. Bravaglia, Tomasetti, they all did cryobiopsy research with Dr. Poletti in Italy. They reported some standardization, right, in interpreting the cryobiopsy. So they recommend list staining techniques they used. They actually propose to have a diagnostic report for each sample, whether it's central, when there's 40 or more percent or component of bronchial or bronchiolar structures, or peripheral sampling, which is at least 60% of alveoli with or without pleura, which I always try to get it without pleura, because if I get it with pleura, most likely we'll have a pneumothorax, but still, more to come, right? And then have a final report considering information present in all samples analyzed. So whether you have RBILD, DIP, et cetera, and the level of confidence. From Coldice, the 2020 study that I was saying, it showed moderate agreement with transbronchial lung cryobiopsies and surgical lung biopsies. They compared how many times they could actually find the UIP criteria, right? The histopathologic criteria, and there's 4, and you can read it in here: evidence of marked fibrosis, intra-architectural distortion in a subpleural or paraseptal distribution, patch involvement of lung parenchyma by fibrosis, fibroblast foci, and then absence or features to suggest any other diagnosis. So when they actually applied all of this criteria and classifying by high confidence, intermediate confidence, or low confidence for IPF, the pathologist diagnostic confidence for surgical lung biopsy was, for the high confidence was much larger than with transbronchial lung cryobiopsy. The intermediate was kind of like okay, and the low confidence was more favorable to surgical lung biopsy. And why is that? Remember, again, we're talking about the 4 cardinal features, right? So because of the nature of transbronchial lung cryobiopsy, you're not going to have pleura all the time, and you can see it in here. Surgical lung biopsy is going to have 100% of the times pleura just because of how they go inside the chest, as opposed to transbronchial lung cryobiopsy. The patchy fibrosis, the fibroblast foci, and the absence of alternative diagnostic features are almost kind of like the same in here. So when you group within all 4 features observed, 94% with surgical lung biopsy, 20% with cryobiopsy, 3 out of 4 obviously favoring cryobiopsy, and so forth. So when they did the analysis and combined patchy fibrosis, fibroblast foci, and absence of features to suggest an alternate diagnosis, meaning we forego the need for pleura, the odds ratio was pretty high to find UIP in surgical lung biopsy. Remember, again, Coldice compares surgical lung biopsy and cryobiopsy, or the combination of fibroblast foci and an absence of features to suggest an alternative diagnosis. It was equally predictive of UIP, right? So the sensitivity and specificity of these 2 or 3 diagnostic criteria with a corresponding surgical lung biopsy that will demonstrate UIP pattern of injury, you'll actually find in the sensitivity in 82% and specificity 84%. So they actually do an alternative criteria for cryobiopsy, which they say may be or may not be present, the pleural component. But if you have patch involvement, fibroblast foci, and absence of features to suggest an alternative diagnosis, you might actually say with confidence that you might actually have the diagnosis with that. So in this interesting editorial by Abudara Maldonado from Vanderbilt, they actually question, right? Or say, the question then should not be whether samples obtained by cryo are histologically equivalent to surgical lung biopsy, using surgical lung biopsy as a gold standard, but rather whether the contribution to MDD consensus diagnosis approaches the one of surgical lung biopsy. So 2 articles that talk about this, a publication in 2022 by Tomasetti et al., Dr. Poletti from Italy group. So what they did is really interesting. They just compare in their institutions transbronchial lung cryobiopsy and surgical lung biopsy, and how much lung biopsy data changed the management strategy in multidisciplinary discussion. So treatment strategy changed in 32% of cryo cases and in 38% of surgical lung biopsy cases. Remember again, when I was showing you the prior studies in which typically multidisciplinary discussion, you just do history, lab values, then you add the CT, and then after that you add biopsies, right? So interestingly enough, whatever you actually got, but it was lung biopsy, it actually changed how they thought about these patients. And this is another way to just look into it, right? So you have 426 patients, more cryo than surgical and biopsy, but cases reclassified after biopsy alone, 20%, which is a significant amount. But then change in multidisciplinary discussion confidence after biopsy, it also increased a lot. So in the very end, you see in here again, that there was a significant change in terms of treatment strategy after you obtain lung biopsies. And this is another one that was published in 2020, but it's kind of like the same, only that they are adding cryobiopsy, and the design is pretty interesting as well. Is clinical radiological first, and whether you have a consensus or not, and if yes, the consensus likelihood in percentage, then you add BAL. Then you add BAL and transbronchial lung cryobiopsy, and if you don't know much, you proceed to surgical lung biopsy, like in a staggered fashion. So you see in here, clinical radiological only. The confident diagnosis is on top. So clinical radiological high confidence in diagnosis was 11%. 38.3% was provisional diagnosis, or a confidence of 70 to 89. Provisional diagnosis, we're not really sure what it is, 36%, and 13%, we don't know exactly what we're looking at. When you add BAL, interestingly enough to me, just BAL, there was not much change in terms of the provisional diagnosis, but confident diagnosis actually increased, almost double. Right? But you see in here, once you add cryobiopsy, you went from confident diagnosis of 11% to 22 to 54%. The provisional diagnosis remained, actually decreased a little bit, right? But everything got better. So now you ask me, okay, but the surgical lung biopsy is the gold standard. So whenever they added surgical lung biopsy in 9 patients, remember this is the column or the row for the cryobiopsy. So whenever you did surgical lung biopsy, the confident diagnosis didn't change too much, maybe 1%. The provisional diagnosis of high confidence never changed too much. So basically we're talking, and it's the same thing that we found in the Coldeye study, is when you are highly confident of a diagnosis on cryobiopsy, it's probably going to correlate pretty well with your surgical lung biopsy. When you have moderate confidence of a diagnosis through transbronchial lung cryobiopsy, surgical lung biopsy may help you, but in cases in which there's a low confidence or it feels that it's unclassifiable, even surgical lung biopsy is not going to help you. So we'll switch gears a little bit in here, and this is from the 2018 respiration expert statement. So indications for cryobiopsy, again, diffuse parenchymal lung disease, in which tissue diagnosis is indicated, meaning clinical radiological data doesn't give you a sense of what's going on. Contraindications as for anything related to bronchoscopy, hemodynamic instability, bleeding disorders, anticoagulant therapy, thrombocytopenia, platelet count less than 50,000, and relative contraindications, pulmonary hypertension, severe restrictions, severe decreased diffusing capacity, or patients that are really sick, right? This is an article that was published in 2019, actually, again, from Vanderbilt, which are really experts in cryobiopsy, and they published their 30 and 90-day mortality. So a retrospective review of case series. In 4 years, they did almost 200 cases. And what they actually found is that 4 patients died within 30 days, or 2.03 of the cohort, and 5 patients died within 90 days, or 2.54, which probably is acceptable numbers. But what they actually saw is that the all-cause for 30-day mortality for inpatient procedures, which they did 3 of them, the all-cause 30-day mortality was extremely high. After this, they state that cryobiopsy is no longer offered to inpatients with acute diffuse parenchymal lung disease exacerbations in this institution. That brings us to here, which in the old days, I would say, we were actually just focused on finding diagnostic yield numbers, pneumothorax numbers, serious bleeding numbers, and then mortality. All right, and this is from the 2018 document again. The diagnostic yield was over 50%, and the pneumothorax went from 0 to 26 based on all these studies in here. Serious bleeding was all over the place, and mortality was less than 2%, which the case series from Vanderbilt actually tell us about as well. Well, nowadays it's a little bit more accepted, or at least there are more centers that are willing to publish about their experience. And I'll let you know a little bit about the experience around the world of some of the case series that I found. And it goes all over it's all over the globe. Ikeda in Japan, they have 38 patients. The MDD diagnostic yield was 65, so a little bit lower than what is quoted. The bleeding, and again, we don't know exactly how to quantify bleeding, was 15.8. Pneumothorax was really low. Remember, again, the meta-analysis called like double digits, but what they did is they did endotracheal tube, Fogarty balloon, and fluoroscopic guidance. Davidson et al. In Denmark had a little bit of more robust case series. Their diagnostic was a little bit better. The bleeding was kind of like the same, and the pneumothorax rate was in double digits. And again, endotracheal tube, Fogarty balloon, and fluoro. Ran it all from Turkey, similar numbers. The diagnostic took a little dip. Bleeding was a little bit higher, depending on how you think you're gonna report bleeding, of course. And then the pneumothorax rate was again like 15 to 14%, but they actually did rigid bronchoscopy instead of flexible bronchoscopy. They did a Fogarty balloon and fluoro as well. And this group in Argentina had 52 patients. The diagnostic was higher. There's no mention about bleeding, and the pneumothorax rate was 25, so they probably were looking to obtain pleura probably. And they used ET tubes, Fogarty balloon, and fluoro as well. So you see that places or countries around the world are really interested in just doing something else for their patients, because we know that the addition of tissue from patients with unexplained or undefined diffuse parenchymal lung disease helps better in multidisciplinary discussion. There's other things, right? As everything in life, if you get comfortable with your technique and you are having great results, and the complication rate is small, you venture yourself to do something else. And there's certain things that I've found in the web, in PubMed. And this is a publication that we were part of this. Dr. Benson was here in Cincinnati that went to Einstein. So he published a two-institution experience with cryobiopsies in patients with acute hypoxemia, respiratory failure, and diffuse parenchymal lung disease. I'll give myself a little pat in the back. I'll tell you about our experience in sarcoid here. This third publication is really fascinating to me. I'll let you know a little bit more, coming from Japan. And there's another one that they're using. So the first one is for reassessment of treatment in a clinical course of diffuse parenchymal lung disease that was diagnosed with surgical lung biopsy. And the second one is doing the cryobiopsy technique for peripheral lung lesions, not diffuse parenchymal lung disease, but peripheral pulmonary lesions. So this is the one that we're talking about. So patients that generally are in the ICU, they have acute hypoxemic respiratory failure. They have bilateral pulmonary infiltrates, we just did antibiotics, we just did diuretics. They're still requiring a lot of oxygen, and we don't know exactly what's going on. So does it make sense to do a lung biopsy at that moment? So this is a case series in 2 tertiary academic medical centers. Cryobiopsy was done in 17 patients, 12 at bedside without fluoroscopic guidance, and 5 in the procedural area. The pathology diagnosis achieved in 15 patients, not multidisciplinary discussion, but a histologic diagnosis was 88%, with significant changes in management in all patients. Just because I think we didn't do all of this cryobiopsies with fluoro guidance, and obviously patients are sicker, so I guess that the lung parenchyma is more frail. 35% develop a pneumothorax, and then 29% ended up with a chest tube. And again, because it's a small number case series, the numbers look bigger than what they are. Or it's probably, if we would just done 100 patients, we would have seen this as well. Moderate bleeding was only observed in 1 patient or 6%. And the ICU mortality was really high, but none due to transbronchial lung cryobiopsy procedures. At least if my memory serves me right, a lot of our patients, we just diagnose them with diffuse alveolar damage features. And we know that if you find that in surgical lung biopsy, the mortality is really high no matter what you do. And in some cases, having that pathological diagnosis help to direct discussions with family members in terms of how aggressive they wanted to be with the family members, knowing that diffuse alveolar damage is not a good prognosis to have. This is a study that I did with, I had the pleasure to do it with Dr. Benson and also Dr. Boffman, who is a world expert in sarcoidosis. And what Dr. Boffman actually asked us, and he was really supportive of the program, was, what if I actually send you guys the patients that I think clinically may have any kind of sarcoidosis, primarily neurosarcoidosis, because you're saying that the diagnostic yield for diffuse interstitial lung disease is higher than biopsy forceps. So he provided 35 patients of his own practice, and we had one from another institution, and we had 36 patients in our cohort. The overall diagnostic yield for the whole cohort was 29 out of 36 patients. We had a diagnosis or a diagnostic yield of 81%. Half of the cohort actually ended up having sarcoidosis. So 18 patients actually had sarcoidosis, and they didn't have the typical presentation for, or the typical radiologic findings for sarcoidosis. And what was interesting is we did EBUS and we did cryobiopsy instead of transbronchial lung biopsies. And what we found is that when analyzed on their own, EBUS had a diagnostic yield of 2/3 or 66.7%, and cryo the same. But when you combine both, you achieved 100% diagnostic yield for sarcoidosis. So the thought was that they're complementary in terms of diagnosis. We have been quoted also in other publications, particularly in Lancet and Lancet Respiratory Medicine, that cryobiopsy sometimes is good also to just rule out other conditions that may mimic sarcoidosis. And here in Cincinnati, we are in the Ohio Valley, and there's a lot of histoplasma, so we found a couple of cases with that as well. So there was no significant bleeding, and the pneumothorax rate was around 11%, which is in line with other reports. This is the study that I was mentioning before. I find it fascinating that the design. So it's a retrospective study in a single academic medical center in Japan. There are 31 patients that were diagnosed with diffuse parenchymal lung disease with surgical lung biopsy who progressed during their clinical or treatment course. And because they deteriorated, they were no longer fit for surgical lung biopsy. So what they did is, okay, well, we're just gonna do a cryobiopsy and see what we find. So they had 2 independent pulmonologists that selected clinical diagnosis, treatment strategy, and they also render a confidence level prior to the cryobiopsy, and they reach a consensus for that. And see here, it's a little bit busy, but bear with me. So 7 patients with clinical diagnosis for pulmonologist A was changed after the cryo, 5 for pulmonologist B, and the consensus, they had 6 patients out of 31 that changed also after they did the cryo. The treatment strategy is also changed. For pulmonologist A was 22%, for pulmonologist B was 25%, and for consensus was 19.4% were changed. So it was interesting that, again, right, as we were mentioning before, you don't know what's going on with your patient with transbronchial, with diffuse parenchymal lung disease. You do some sort of biopsy and it helps. In this particular cohort of patients which underwent surgical lung biopsy, now they were not as fit to undergo a second surgical lung biopsy, transbronchial lung cryobiopsy helped to change the treatment strategy. And definite or high confidence of the consensus treatment strategy was before adding cryo was 55% and 84% after cryo. 6 patients actually had moderate bleeding. There was no pneumothorax. So again, helpful also not to diagnose diffuse parenchymal lung disease, but at least helpful when you need more information, right? And then the last one that I was mentioning, this is a retrospective study in a single academic medical center in Japan as well. They actually did cryobiopsy, or they added cryobiopsy on top of the usual biopsy forceps, needle biopsy brush for peripheral pulmonary lesions. They have 257 patients. And the overall diagnostic yield adding cryobiopsy was almost 90%, which I think it's amazing. 22 lesions were diagnosed with transbronchial lung cryobiopsy alone. So there was an increase in diagnostic yield by 8.6. Severe hemorrhage or bleeding was 1.2% and pneumothorax 0.8, which I think it's great. I mean, it's fascinating how the pneumothorax incidence changes. And additional things that they found also is, as everything in navigational bronchoscopy, the presence of a bronchus sign and the presence of either eccentric or concentric emitted probe actually predicted to have a diagnostic cryobiopsy. But that makes sense as well, because it's just another tool, right? And you're going through the same pathway anyways. But still, you know, fascinating. It was published in 2021. Okay, so then fast forward in 2022, May the 1st, when I was about to just start making my presentation, and hot off the press. That's why I just stayed in here, and we can talk about it. But I think right now we're not at the era in which we're questioning whether cryobiopsy is feasible or not, if it's safe or not. I think right now it's from to infinity and beyond. It's actually, well, not comparable, but has moderate concordance with surgical lung biopsy. And we have two publications that actually kind of gave a little bit more relevance to this technique. First, a systematic review in the White Journal, published online on May the 2nd, which was a meta-analysis of transbronchial lung cryobiopsy. And then the updated IPF guidelines that was published in the Blue Journal on May the 1st. In essence, the first one from the White Journal, the meta-analysis, is very low quality evidence indicated that transbronchial lung cryobiopsy has a diagnostic yield of approximately 80% in patients with ILD with manageable complications. And in the 2022 IPF guidelines, there's a conditional recommendation to regard transbronchial lung cryobiopsy as an acceptable alternative to surgical lung biopsy in centers with appropriate expertise. And yes, that's one thing that I will make a remark as well. So hopefully in the past few, less than an hour, I was able to just communicate a few things. One, that right now we have great evidence that transbronchial lung cryobiopsy has moderate agreement with surgical lung biopsy, and it's an acceptable alternative for the diagnosis of ILD, particularly in patients that are not fit for surgery. Obviously, the patients that can undergo a surgical lung biopsy, by all means, that's a gold standard. That's what we know the best. Please submit your patient for surgical lung biopsy. I personally think that the agreement between cryos and surgical lung biopsy would increase if we would follow the modified diagnostic criteria from COLDICE that I showed you, meaning don't rely much on the presence of pleura to just make a call. And that's one thing that we've been blessed in this institution, to have a great group of pathologists that are really confident of with the smaller sample that is a cryobiopsy as opposed to a surgical lung biopsy to call the histologic diagnosis. Transbronchial lung cryobiopsy has other interesting applications beyond ILD diagnosis only. And last but not least, what I was saying, cryobiopsy should actually be offered in centers of excellence. So you can actually have a great proceduralist group, but if you don't have a multidisciplinary discussion, you don't have ILD specialists, they're not going to use your biopsies. If you don't have a good group of pathologists that can help you to interpret or maximize the chances of having a solid diagnosis with smaller biopsies, they're not going to call it. And obviously, if your radiologists are not comfortable with calling certain patterns of lung injury, then you're going to have trouble too as well. And that's the reason why I think there's so much variation in terms of the publications that you find up to now. But I think it's really exciting. I think at least we've made a small leap into what is the future. Before 2018 or so, it was more like, how do we make this procedure as safe as possible? So the recommendations are, because there's going to be brisk bleeding with your cryobiopsies, have your scope there, have your Fogarty balloon, and talk with anesthesia and try to make this procedure as safe as possible. I personally believe that if you want to do cryobiopsy, you'll need to be trained on that. It's not as easy as it looks. But again, it's only one part. You actually have to have a great framework for which you're going to have a better outcome in terms of diagnosis, treatment, and prognosis for your patients. And again, whether there's still debate on endpoints, diagnostic yield, degree of bleeding, anything else, I think cryobiopsy is here to stay as a diagnostic procedure for ILD and other applications. And that's what I wanted to finish with Buzz Lightyear to infinity and beyond. I will be open for questions, and thank you for your kind attention.
Thank you so much, Dr. Aragaki. That was a wonderful talk. For our audience, if there's any questions that you have for Dr. Aragaki, please feel free to type them in the chat box. Dr. Aragaki, I'm getting a couple of questions about the technical aspects of how to do the transbronchial lung cryobiopsy, as far as preferred probe size and size of the biopsy, anything that you aim for in particular when you're doing the procedure.
Yes, so we were not able to just publish our initial experience back in 2015 and 16 with the first fellow that I trained, but interim data analysis suggested, and we were using the 1.9 versus 2.4 cryoprobe, and there was no difference in diagnostic whether you use a 1.9 and 2.4. There's one publication that I didn't add because we would have been talking a little bit longer tonight, but there's enough data to suggest that there's no difference. Again, no difference between 1.9 and 2.4 cryoprobes. Obviously, the 2.4 cryoprobe is going to create a bigger ice ball. Hence, if you actually weigh the biopsies are going to be a little bit heavier on the 2.4, but that is at the expense of getting a little bit more bronchial tissue also. But the alveolar tissue obtained with a smaller cryoprobe is going to be enough for you to get a diagnosis. Me in particular, just because the way I was trained, and probably it was because we have more reusable 2.4 cryoprobes, I just love the 2.4, and that's the only thing that I like to use. Now we have the 2.4 and 1.7, so my IP fellow is really smart in terms of, oh, Aragaki's on 2.4 on everybody. If there's another 10, he uses a 1.7, but there's no difference in that. For the procedure itself, you can review the 2018 respiration article and the CHEST 2020, and all of them actually highly recommend to have some sort of blocker, because the biopsies themselves, when you are actually freezing with a cryoprobe, they are bigger than the diameter of your working channel. And for example, in this institution, we use therapeutic scopes. Just because we do it a little bit different. Instead of using a blocker, we use a second therapeutic scope to just wedge. But the general recommendation is expect some bleeding from the cryobiopsy. So you actually need to have some sort of control of the bleeding that ensues when you actually take your video camera or your bronchoscope and the cryoprobe and the biopsy itself out of the airway. So the general recommendation is to just have some sort of balloon, a 4-gauge balloon or a bronchial blocker. And once you actually pull instrument, you just inflate the balloon and just wait a couple minutes until you assume that there's hemostasis, and or you thaw the biopsy from your cryoprobe, and then you just go with your bronchoscope and just see what happened. With the cryoprobe, AirB cryoprobe 2.0, there's a lot of different programs. There's a program specifically designed for transbronchial lung cryobiopsy. So the default freezing time is 5 seconds. In here, when we're using the reusable cryoprobes, just because with time they get bent, they get a little bit of wear and tear, instead of just kind of like boxing ourselves in a 4 or 5 second period of freezing where you actually press the pedal, we were actually measuring how long would it take us to just form an ice wall that looks adequate to just get a cryobiopsy. For the 1.9, we were looking or aiming for a 13 French diameter, and for the 2.4, a 16 French diameter. But in essence, when you get the cryobiopsy itself and you just get it and put it on formalin, the general recommendation is if they measure, I mean, obviously I don't encourage you to just measure the the biopsies, but they say that when you actually have it in pathology, you should actually aim to have at least a diagonal diameter of more than 5 millimeters to just call it adequate. But that's why I was saying also, right? Is you can also get the biopsies, but once it goes to the pathologist, then you need to have a pathologist that is comfortable calling the diagnosis they think it fits best with less, tissue.
Is there any difference in yield doing biopsy from one site versus multiple different sites?
Yes, excellent question. So didn't mention that, but it's an excellent question. So at least what we do in Cincinnati is we try to mimic what our thoracic surgeons do. So initially, when we were actually doing our initial experiences, we're actually getting 2 from the upper, 1 from the middle, and 2 from the lower, particularly from the right lung, because the right lung is shorter and it's straighter. So it's easier for us because we don't use a balloon, we use another scope to just get in once we retrieve the sample. But you're right. If you're gonna do a cryobiopsy, your diagnostic yield is gonna increase if you take a biopsy from a different lobe as opposed to be getting 2 or 3 or 4 biopsies from the same lobe. So, or from the same segment, I would say. So yes, there is an increase in diagnostic yield when you biopsy more. Preliminary data that we have that we were not able to publish, we're trying to compare 5 versus 3, and I think what we concluded, but we haven't published yet, is if you get 3 good cryobiopsies, 1 from the upper, 1 from the middle, and 1 from the lower, it's enough. You don't need to take more. But again, that depends also on on your pathologist and everybody else that comes into this multidisciplinary approach, particularly for diffuse parenchymal lung disease. For peripheral lung lesions, a little bit different. I think that the answer for that is mainly, do you get something that correlates with what you think it is? But there's interesting application of cryotherapy way past diffuse parenchymal lung disease, and I think it's important.
Other than bleeding, any pain that's involved for the patient that's getting the cryobiopsy?
Excellent question. So I always tell my patients that a lung biopsy should not hurt, right? Because you're not getting into the territory of the pleura, particularly parietal pleura. Have we gotten cryobiopsies with pleura? Yes. With other other tissue, once I guess we went into the diaphragm, but thank God nothing happened. And it's going to happen, right? I mean, we're just trying to get as much information as we can, but no, the cryobiopsies themselves shouldn't hurt. However, and this is fascinating, and I don't know if there's any correlation or not, because we had this straight collaboration with Dr. Boffman. For some reason, and probably I am wrong, but with my mentor, we noticed that when we were biopsying or doing cryobiopsies on patients, middle-aged female obese patients with a high suspicion for sarcoid, they had this intense pleuritic chest pain post-biopsy, and we would actually take 2 or 3 x-rays. We would actually do ultrasounds, serial ultrasounds. We couldn't find the pneumothorax, but they had exquisite pleuritic chest pain. Does it happen all the time? No. Maybe I'm biased, and I apologize if I'm sounding kind of like like unprofessional, but it was really fascinating to us, and I think there was something in there that we still don't understand. I don't think every single patient that I describe, which I was joking with my mentor, I call it the Benzaken sign because it's unexplained. I mean, we just biopsy them and they just have pleuritic chest pain, but we never got to the bottom of that, and I haven't seen that for a while. But typically our patients do well. It's kind of like the same thing that you do or that you go through with a patient that you do in a transbronchial lung biopsy. It shouldn't be different. My opinion, and that's mantra from my mentor as well, is the most severe complication of a procedure is that you don't get the answer, number 1. Number 2, if something happens, you take care of it. But with all said, cryobiopsies is not something that I would suggest for everybody to start doing it. You probably are going to need some sort of training for that. Or if you feel comfortable, I mean, obviously I'm no one to just tell you not to do it, but the recommendations are just have a defined protocol, have some sort of bronchial blocker to just help you with the bleeding. And once you get more comfortable, then you can actually do more, I guess.
Awesome. Well, thank you so much for taking the time out of your day to give us this talk. We really appreciate it. And I'd like to thank everyone that attended the session today. I hope you all have a good night.
Thank you very much for the invitation. Take care.
Thanks. Bye-bye.